Okay, so here I will turn it to Dr. DiNardo to discuss our next case. Please, Dr. DiNardo.
Absolutely. So our second case is a 75-year-old gentleman who is presenting with pancytopenia in the setting of an upper respiratory tract infection. So his counts are on the low side, a white count of 1.5, hemoglobin 8.2, platelets of 94,000. Neutrophil count is low. He has normal other organ function, renal function, liver function is okay. His LDH is mildly elevated. His performance status is 1. He has a past medical history significant of type 2 diabetes and coronary artery disease and atrial fibrillation. He is referred to a hematologist where a bone marrow evaluation is performed and does confirm a diagnosis of AML. 32% blasts with underlying MDS-related changes, trisomy 8 cytogenetics, and an NPM1 and an IDH2 mutation. And so, the first question is, is this scenario commonly seen, and why in particular is this a challenging case? And I'll pivot back to Dr. Daver to kind of give his thoughts on this, and then we can go into a little bit more detail.
Yeah, thank you very much. Absolutely, very common case. I would say the age range and presenting features are almost close to 30 to 40% of the AML patients we see above 70 years of age. Mutations are interesting. This patient does have slightly favorable mutations, NPM1 IDH, but does have background MDS. I think the major challenges are the age of this patient, 75, where intensive chemotherapy, in my opinion, I know many of us at MD Anderson will agree, is something we would not consider at this age for 99% of our patients. So I think we're looking at lower intensity, but now effective lower intensity combinations, which I'm sure you'll discuss.
That's exactly right. I think, it's a particularly challenging case because we have so many different options available. So these are all options that are available, approved for a patient. So, do we give an intensive chemotherapy-based regimen with 7 and 3 with gemtuzumab or CPX-351 given the underlying MDS changes? Or do we prioritize a lower intensity combination, hypomethylating agent with venetoclax, low-dose ARC, venetoclax classic? The patient has an IDH2 mutation, so would we think about an azacitidine-containing regimen, either alone or with azacitidine? And I think as Dr. Daver mentioned, that 75 does not preclude intensive chemotherapy, but given that our lower intensity therapies now are showing kind of equivalent responses with excellent durability, the question is, do we really want to prioritize intensive chemotherapy in someone who is on that older age range with underlying comorbidities, even though the performance status is 1? And so this just provides a little bit of data showing that, 30-day mortality does increase with increasing age and increasing performance status, which really does, I think, have to factor into the decisions we make. And so in terms of optimal treatment choices, I would say in general, intensive chemotherapy for someone in their 70s who has underlying comorbidities, especially someone with, NPM1 IDH mutations, that this patient is going to respond incredibly well to lower intensity combinations. And so we actually have different options available. I think the vast majority of providers throughout the United States are going to prioritize an azacitidine venetoclax regimen based on the VALI-A data, which is very appropriate. We have a more than 70% composite remission rate. Median survival is about 2 years. And patients with that specific, NPM1 IDH2 co-mutations are doing particularly well. But there is also data with aza and azacitidine with a composite remission rate above 60% and a similar median overall survival. So that wouldn't necessarily be an incorrect option either. And azacitidine alone, I would really kind of restrict for a particularly frail patient that you really want to focus on just an oral outpatient regimen. In terms of toxicity management, I think, we'll get into this probably a little bit more, but just to provide a little bit of guidance, I think when you're using azacitidine and venetoclax, the things you really want to be aware of are the risk of cytopenias and myelosuppression, because even though we call this a lower intensity regimen, we absolutely see cytopenias that oftentimes go beyond that 28 days. So again, that 28-day cycle is a bit of a misnomer. Oftentimes we're giving patients 5 or 6 week cycles now. The most important thing is to do a bone marrow around about the end of the first cycle, somewhere between day 21 and day 28. to see if your patient's already in a leukemia-free state, because if you've cleared the leukemia and the counts are still low, then the counts are still low because the patient hasn't had time to recover their bone marrow function yet. So you wait a week or two, you hold the venetoclax to start the second cycle. So that's just a really important point. And then also being aware of dose modifications with azoles. There are adjustments which are significant. So a 50% venetoclax reduction with moderate CYP3A inhibitors like fluconazole or isovuconazole, and at least a 75% reduction with the strong ones like voriconazole, posaconazole, with a package insert specifically recommending 70 milligrams of venetoclax when you're using posaconazole. So just important things to be aware of. So Dr. Daver, any particular pearls of wisdom in terms of treating a patient if you've decided that you're going to do an HMA ven, and how you would kind of optimize their therapy?
Yeah, absolutely. I mean, this is a regimen that I think we're using very extensively at MD Anderson. We've been using it for the last 5 years, treated hundreds of patients. And as you said, I think the key factor here is that we cannot really try to adhere, and we should not try to adhere to these 28-day cycles. I would say in our experience and published data, most of these cycles are running 35, 42 days, and that is okay because it is not impacting the remission rates or the MRD. The second factor is, as you said, we do a planned staged interruption of therapy, and many large academic centers across the US are doing this now, where we confirm a remission with the bone marrow around day 28. Once we show there's marrow remission, often we see that's with hypoplasia, aplasia, insufficiency, then we know that this is drug-related myelosuppression. We safely hold the venetoclax for 12 to 14 days, if needed, give growth factors, and then we're usually able to continue with cycle 2, where we usually shorten the venetoclax to 21 days, sometimes even down in subsequent cycles to 14 days. So I think, as we say, there's an art of venetoclax. It's a very effective drug. However, it's not like using AZA alone, which is, as you know, a lot of emails and questions we get from community. You cannot just give it and keep giving cycles 28 days. You need frequent labs, early marrow, confirmed remission, and hold therapy. So I think if you do all that, though, this is really a very, very effective and safe regimen.
Absolutely. We'll move on to the third case, which is one where I think it is a little bit challenging. I think the jury is still out in terms of what the best treatment strategy is. And so interested, Dr. Daver, to hear your thoughts on this. So this is a 65-year-old female who's presenting with pancytopenia, again, in the setting of an upper respiratory tract infection. So that, first sentence is very similar to our 75-year-old that we just talked about. Counts are low, normal renal and liver function, LDH is mildly elevated, again, very similar. Performance status is 1. But the difference here is the past medical history. So this patient has a history of breast cancer, has had chemotherapy and radiation, although it was many years ago. And this patient's bone marrow evaluation shows us, again, elevated blasts with underlying MDS-related changes, but the genomics are different. So this patient has complex cytogenetics, a deletion 5q, a monosomy 7, and on a NGS panel looking at common AML mutations, a p53 mutation is detected. So this patient started off very similar to our other patient, but again, the genomics are different. So this patient has complex cytogenetics and a p53 mutation. So treatment decisions, while many of the same treatment options are available, the expectations are a little bit different. And Dr. Daver, I wonder if you could just tell us a little bit about kind of this scenario. Is this something that we see often, and why is this particularly challenging?
Yeah, thanks, Dr. DiNardo. This is a very challenging case, for us, as you know, kind of now probably one of the key spearheads for research in AML and MDS is how to address TP53 mutated AML and MDS. And that's one of the reasons, because venetoclax has been so effective and safe and improved outcomes in many, many subsets of AML. However, unfortunately, TP53 remains where over time, with more analyses, updated data from the phase 1b studies, the Viale studies that you conducted, as well as now our internal data set, seems to suggest that venetoclax has marginal and some would argue no improvement in the TP53 mutated AML. So this population remains one where we are still in a major unmet need. Now there are new drugs that you will discuss that we're hopeful about. But today, if you look at a TP53 mutated AML, even if you look at venetoclax data, the response rates are about 50-55%, which is not bad, but the median survival is only 5 to 7 months, which is not better than we were getting with DAC or AZA alone. So this is, I think, the biggest challenge for this patient.
That's exactly right. So again, you can see there are many different treatment options. This is a 60-some odd fit patient, PS of 1, no significant underlying comorbidities that would preclude intensive chemotherapy. So we could think about 7 and 3 or CPX-351, given this patient has an antecedent MDS and a therapy-related AML. We can think about hypomethylating therapy. There's been data on 10-day decitabine as being particularly effective at eradicating, at least for a short period of time, p53 clones. And then the venetoclax combinations, as well as clinical trials, which are showing what appears to be particular benefit in patients with p53 mutations. And that in particular is APR-246, now eprinetapopt, and the CD47 antibodies, including magrolimab. So just to kind of remind the audience that we think this doesn't happen that often, but it really is almost 20% of our AML patients can be therapy related or in the setting of complex cytogenetics with a p53 mutation. So it absolutely is the minority, but it's a significant minority, and one that we absolutely need to be kind of thinking about and trying to optimize their therapy. So we have many different treatment options, and so I think compared to a standard hypomethylating agent regimen alone, or a standard 7 and 3 based therapy where we can expect a remission rate under 30% or so. There are some hints that remissions are higher with some of our newer therapies. Hypomethylating agent with venetoclax, for instance, with the VIALE data, had a CR/CRi rate of 55%, which is certainly improved compared to azacitidine alone. But then when you look at the overall survival, we're really kind of yet to kind of really move the needle in the sense where kind of standard overall survival for a p53 mutated patient is only 6 months or less. And so with many of our new therapies, we're still kind of right at that level. And that's why I think the new trials involving APR-246 or magrolimab are seen as so exciting in our field, and hopefully the ongoing data will kind of prove that this is indeed something that is improving the duration of remissions and overall survival in our patients. So just going through a couple of the trials in particular. So we know, of course, that CPX-351, based on a randomized phase 3 study, shows an improved overall survival in patients who were eligible, which this patient certainly would have been with the therapy-related AML, with a improved overall survival. When you look at subgroups, and P53 is the column on the right, there are, again, evidence that intensive chemotherapy is probably not the best option for patients with p53 mutations. And so in this p53 mutated group, CPX versus 7 and 3, you look down and the composite remission rate is fairly similar, and the median overall survival, unfortunately, still under 6 months. We talk about 10 days of decitabine. This is a kind of an infamous clinical trial that was published in the New England, looking at the fact that we can clear p53 mutations incredibly well when you're giving 10 days of decitabine for the first few cycles. However, those remissions are unfortunately quite short-lived, with a survival that is kind of not improved, unfortunately. And so now we think about venetoclax combinations, because venetoclax combinations, I am definitely a believer, and they have definitely taken the world by storm in terms of the efficacy in many different subsets. But you look at p53 mutations, which again is the column on the right, and the composite rate is good. Especially with azacitidine, 55% composite remission, as is shown here. But again, durability of these responses is unfortunately still not where we want it to be, right around 6 months or so. And so just a little bit of information about APR-246, which is a first-in-class small molecule, which is inducing apoptosis through reactivating the wild-type p53 conformation, with data in a small number, just a handful of patients so far with AML, although there are many more with MDS and p53 mutations, which show, again, a composite remission rate, a CR rate of about 50%, but an overall response rate higher, and a duration of remission kind of extending beyond even the overall survival in many of our other studies. So the hope is Many of these patients are coming off for transplant. Many of these patients are doing well. The follow-up is really short, so time will tell. And there are ongoing clinical trials looking specifically at this in a randomized fashion. And then the CD47 antibody, which has been presented by both Dr. Solomon and Dr. Daver, so he can give us his expert opinion looking at patients with AML. And this was not selected for patients with P53 mutations, but in a sizable enriched population of 12 patients with P53 mutations, the response rate was, 3/4 of patients are responding. And those patients who are responding, that again, the follow-up is short, but the 6-month overall survival is 90%. So again, far exceeding the median overall survival in historical expectations. And so, I think that is a hopeful rose-colored twist to what is a incredibly challenging patient population to treat that is still kind of an area where improvements are needed. So Dr. Daver, what do you think?
Yeah, I think we're very excited. That's our nature, to be optimist in the field of acute myeloid leukemia. As you mentioned, we have been very involved with both magrolimab APR. We have seen some really outstanding responses in some patients who I think otherwise would not have responded. But I think we need more time. And at this year's ASH, there will be the abstracts are out, so we can actually share some data. There will be an update on at least the AZA magrolimab. The AZA APR is in a phase 3 locked study right now, so we won't know till early next year. But now with about 35-40 TP53 mutated, the responses are holding at around 75%, and the median survival is emerging now above 12 months. So we're hopeful that this is something real. Still, 12 months is good when we talk about 6 months, but we want more. So the question is, can we move it further with triplet and other combinations? And I think that's what we're looking at. The other issue, which we see a lot with TP53 mutated AML, as you know, is that they also tend to have much more myelosuppression with the therapy. So our early mortality rates are quite high. So I think these are patients that we would all strongly recommend go on trials. These trials for APR and magrolimab are open now at least 25-30 centers in the US. So if you see such a patient, my strong recommendation would be contact your academic expert in your community, or contact us if you like. And really, these patients would be best served on getting on one of these doublet or triplet trials.
Yep, I completely agree. My bias is that I think it is a very unusual patient with a P53 mutation that's responding and doing well with standard intensive chemotherapy. So I prioritize lower intensity regimens because the outcomes are about the same, but without the toxicity. But absolutely agree that with that clinical trials and in particular the ones that we were just describing are hopefully going to be the way to go and what we should think about for patients that are presenting in this situation to our clinics.